incidences and prevalence is very high. Uh, and of that, there were over 135,000 mortalities. So cryptococcal meningitis is responsible for 15% of all HIV-related deaths. So it's something that needs to be adequately addressed and with a lot of urgency. So the signs and symptoms. So this one, it being a fungal infection, it doesn't have a lot of acute setting compared to bacterial meningitis. So the onset can be within 1 to 2 weeks after an infection. The patient may present a lot with fever, malaise, headache, photophobia, and stiff neck, and vomiting. Of note here is you'll find the patient presenting a lot with stiff neck and photophobia. If you are able to review these patients in the ward, they are either sleeping or have covered their heads up. And if you make an inquiry, they'll inform you that the light is really bothering them. The other signs that mostly occurs due to increased intracranial pressures, the patient may present with lethargy, confusion, visual and hearing loss, especially due to the effect on cranial nerve 6. So its diagnosis, this one relies a lot, number one, on the clinical examination that the physician or the doctors are going to make. So you need a detailed clinical history. So you are going to assess for fevers, headaches, photophobia, the immune status, because as you have seen, cryptococcal meningitis is very common among patients with retroviral disease, and also patients who might be on other immunosuppressants. Uh, a physical exam is also necessary. So you're also looking at skin lesions, and you may need to do a neurological exam and a mental state exam. After that, one can do a serum cryptococcal antigen, which can help to indicate either cryptococcosis and the risk of cryptococcal meningitis. Then the next thing should, where possible, should be neuroimaging, especially a CT scan. This one helps to rule out the presence of mass lesions and also help to diagnose hydrocephalus. And for patients who have mass lesions, the lumbar puncture should not be done. So, if where possible, a CT scan, then do a lumbar puncture. And then finally, a lumbar puncture can be done. So, when doing what we are going to assess is the intracranial pressures, of which in cryptococcal meningitis, they're usually elevated. You draw out the cerebrospinal fluid and take it to the lab where you're going to check for the cryptococcal antigens. You'll perform an Indian ink on the fluids and culture, and also assess for hydrocephalus. So principally, the culture would take between 3 to 4 days. So an Indian ink is usually the first point at which the CSF fluid is subjected to in the CSF crack. Cultures helps to determine the sterility of the fluid after pharmacological interventions. In terms of how the CSF fluid would present, appearance, mostly it appears to be, it's usually clear. On its biochemistry, there's usually some slight elevation in CSF proteins. The CSF glucose levels may be normal. In some cases, they might be elevated, and even in some cases, it might be low. Compared to bacterial meningitis, where the bacteria consume this glucose in the cerebrospinal fluid, where it will present with low glucose. The same biochemistry, the CSF fluid may have very low white cell counts, predominantly lymphocytes. Still compared to something like bacterial meningitis, where you may have um polynuclear cells. The opening pressures when you're doing the lumbar puncture is usually highly elevated. Some references we list 20 centimeters of water as the any value above 20, and others we list any values above 25 centimeters of water opening pressures. So the increased intracranial pressures occurs due to a high fungal burden that is in the CSF, which might we increase the viscosity of CSF and also affects its flow between the ventricles. In some cases, we might find very high fungal burdens of over a million yeast cells per ml of CSF. In this particular case, what are the differential diagnoses that you may consider for this patient? Number one would be TB meningitis. So this one would be ruled out by performing a CSF gene expert. Culture for TB takes a long time, but at least microscopy and CSF gene expert would help rule that out. Toxoplasmosis, this one would be mostly diagnosed at the CT scan level when you're doing imaging. Same for lymphomas. In syphilis, you may need to do treponema and non-treponema tests like VDRL. So from these, we are going to consider the treatment phases. What we need to really take home from this presentation is there are usually three phases of management of cryptococcal meningitis. We have an induction phase, a consolidation phase, and a maintenance phase. The consolidation phase is usually 2 weeks. The induction phase is 2 weeks, consolidation is 8 weeks, and the maintenance phase can last for more than a year. And that's for the immunocompromised patients. So the induction phase is basically 2 weeks, and you are going to use 3 drugs with the intention of rapidly clearing the organism from the body. The consolidation phase, this one ensures because viral infection clearance takes a, a long time, you want to ensure that the disease is fully suppressed. And the maintenance phase, which you are going to do for more than a year, that prevents the recurrence of disease after treatment. It's also more like a secondary prophylaxis phase. So this one is continued among the patients, HIV positive patients, until number one, you have ensured that the patients are adherent to ARTs. Their CD4 count is more than 200 cells per millimeter, and that is based on two measurements taken 6 months apart. And they have a very low viral loads, or basically they have suppressed their viral loads. In terms of treatment, as I've said, the induction phase will involve 3 drugs. The recommendation that we are going to give here is you can use a high-dose liposomal amphotericin B combined with flucytosine. So the liposomal amphotericin B will be dosed at 10 milligrams per kg start, plus flucytosine dosed at 100 milligrams per kg per day, but it's given in 4 divided doses, and fluconazole at 1200 milligrams once daily. The consolidation phase, you're still going to use a high dose. In the consolidation and maintenance, you give monotherapy, but we use fluconazole. The consolidation phase will use a high dose fluconazole dosed at 800 milligrams once daily. And in the maintenance phase, you use fluconazole at 200 milligrams once daily. So this is a snippet of the WHO recommendations. I borrowed these from the 2022 World Health Organization guidelines for diagnosing and preventing cryptococcal meningitis among adults and adolescents in people living with HIV. As you can see here, the induction therapy, WHO recommends a high dose of liposomal amphotericin B dosed at 10 milligrams per kg with 14 days of flucytosine dosed at 100 milligrams per kg per day divided in 4 doses, and fluconazole at 1200 milligrams daily for adults. Or for kids, the fluconazole is dosed at 12 milligrams per kg per day to a maximum of 800 daily. The alternative induction regimens, which I'll also show you a small snapshot from our guidelines. If you're not able to access liposomal amphotericin B, you can use the 7-day course of the amphotericin B deoxycholate, or what we call the conventional amphotericin B. We're dosing it at 1 milligram per kg, plus still the flucytosine and fluconazole as listed earlier. But the flucytosine is given for 7 days, and the fluconazole. Still, if you don't have any amphotericin B formulation, you can use 14 days of fluconazole and flucytosine. Uh, of important to note, where there's a lot of emphasis, flucytosine is never given alone due to the high risk of resistance. The consolidation phase, as I've just listed, is fluconazole at 800 milligrams daily, or 6 to 12 milligrams per kg in children. And the maintenance is 200 milligrams daily for adults, or 6 milligrams per kg per day for children. So a critical point is the pharmacotherapy for cryptococcal meningitis. As we are still repeating ourselves, you are going to use either amphotericin B, flucytosine, and fluconazole. So amphotericin B is an ergosterol synthesis inhibitor. Of important to note, it's usually fungicidal. It's actually might be the only drug among these three drugs, it's the only drug that is fungicidal. Both flucytosine and fluconazole are fungistatic. Flucytosine, its mode of action, it inhibits both RNA and DNA synthesis, and also protein synthesis. It's fungistatic. It will have action against Candida species and Cryptococcus species, but it will have no activity against aspergillosis. The advantage with it has very high bioavailability. Actually, in our facility, it's only available as an oral tablet, but the renal clearance is over 97% is cleared through glomerular filtration. And the fluconazole, it's still an ergosterol synthesis inhibitor. It's fungistatic, but renal clearance is 80%. Of note here is flucytosine is easily dialysable. So you must have considerations in patients undergoing dialysis. So we are going to mention a few of those three individual drugs. So as I had said, amphotericin B it's a Pauline antifungal agent. It's fungicidal, but it has very poor bioavailability with low GI absorption. Uh, it has concentration dependent killing. So the more you expose the pathogens or the fungi above the minimum inhibitory concentration, it's able to eradicate the fungal loads. It's actually the main drug that is used for management of serious invasive fungal infections, conditions like aspergillosis, cryptococcosis, or cryptococcal meningitis, a systemic or any systemic fungal infection. It has a wide antifungal spectrum and very low recorded instances of resistance. On its mechanism of action, it usually has four areas. It has a polar head, a hydrophobic polyene chain, a hydrophilic polyol chain, and a hydrophilic tail. The between the polar head and the polyene chain is where it binds to sterol. So it can either bind to ergosterol in the fungi, or it can either bind to cholesterol in mammalian cell membranes. And once it binds, it creates channels through which there's a loss of electrolytes. And what is majorly lost is either potassium, sodium, and magnesium. However, the ergosterol that you find in fungal membranes has a higher affinity than cholesterol. And that's what makes it uh, good in terms of as an antifungal agent. So its side effect, majorly renal. because it has a slightly high molecular weight, so it tends to accumulate in the renal system, where it will cause an acute kidney injury, uh, presenting with reduced blood flow and a reduced glomerular filtration rate. Due to the creation of those transmembrane pores, it will cause hypokalemia with urinary potassium wasting, and hypomagnesemia with urinary magnesium wasting, and polyuria. It can also cause metabolic acidosis, and this is type 1 uh, metabolic acidosis, or what we call distal renotubular acidosis. Of note here is the polyuria is due to its effect on vasopressin, where it induces vasopressin resistance, or what we would call diabetes insipidus. Prolonged use can result in cardiomegaly. Hematologically, amphotericin B is known to cause anemia and thrombocytopenia, and this occurs from its in suppression of thrombopoiesis and hematopoiesis. And also it causes a lot of infusion reactions, which occurs due to release of pro-inflammatory cytokines. So these can present as rigors, chills, and nausea and vomiting. So its administration, or when you're using amphotericin B, you must put all this into consideration and assist in monitoring patients. For flucytosine, it's also called 5-fluorocytosine, or 5-FC. It's a synthetic analog of 5-fluorouracil. So the flucytosine will enter the fungal cell membrane through cytosine permease, which is an ATP-dependent action. Once it enters the cell, it encounters a certain enzyme called cytosine deaminase, which converts it to 5-fluorouracil. So the 5-fluorouracil will combine with uridine monophosphate pyrophosphorylase, which can form either two things. It can either form 5-fluorodeoxyuridine monophosphate, which inhibits the diamide-dilate synthetase and leads to inhibition of DNA synthesis, or it can form the 5-fluorouracil monophosphate, which is further phosphorylated to 5-fluorouracil diphosphate and 5-fluorouracil triphosphate, which is incorporated into the RNA, leading to inhibition of protein synthesis. So one consideration and one thing that makes it unique only to fungi, humans do not have the cytosine deaminase, which now makes us a little bit immune to its effect. However, among patients who may have some um, yeast cells in their GI system, the presence of these cytosine deaminase in these GI fungi can activate the 5-fluorouracil, which is basically an antineoplastic, and that's the main side effect of 5-fluoro of the flucytosine, which is neutropenia. So the two main side effects are bone marrow suppression, which will present with as neutropenia, and acute kidney injury, of which you may require adequate hydration. For fluconazole, I think we have all interacted with fluconazole in our practice. It's an ergosterol synthesis inhibitor, and it will inhibit the 14-alpha demethylase, which catalyzes the conversion of lanosterol to ergosterol. So by giving fluconazole, you will now have a lot of accumulation of lanosterol, causing cell death. The side effect, most common, is drug-induced liver injury, where patients may present with an elevation in transaminases, hepatitis, and cholestasis. Prolonged use, patients may get alopecia and chapped lips. So we go to the next chapter, which is what I would want us to all take home: the administration and dosing of cryptococcal meningitis medications. So as I have said earlier, induction phase, we are going to use liposomal amphotericin B, flucytosine, and fluconazole. So the liposomal amphotericin B uh, contains lyophilized amphotericin B. The ampoule comes as 50 milligrams, which is coated in a liposomal membrane. It's strictly given as an intravenous infusion. We have the deoxycholate. Uh, of note, which can also be confusing to among the users, both the deoxycholate, or what we'd call the conventional amphotericin B, and the liposomal amphotericin B, they all come as 50 milligram ampules. Uh, However, the dosing requirements is different because for the deoxycholate, you are dosing at 0.7 to 1 milligram per kg, but the liposomal, you are dosing it at 10 milligrams per kg start. The flucytosine, what we have in our facility currently is an oral tablet. So we had said this is a synthetic antimycotic compound. It's either available as 200 and 500 milligrams. In our facility, we have it available as a 500 milligram tablet that is cored. It's not film coated or enteric coated. So it's dosed again as 100 milligrams per kg per day in 4 divided doses. And I had said earlier, it's never given as monotherapy due to a risk of resistance. Fluconazole available in different tablet formulations. What we have most common in the market is the 150 milligrams and the 200 milligram tablet. And what we mostly have in our facility is the 200 milligram tablet, and that's the one that is preferred for cryptococcal meningitis. It's used for induction, maintenance, and consolidation, as we had said earlier. So, of note, this is what is recommended in our HIV guidelines that were released this year and also by WHO. So, for the induction phase, you have 5 options. So, the most preferred option is the liposomal amphotericin B, given at 10 milligrams per kg on day one, followed by 14 days of flucytosine at 100 milligrams per kg per day in 4 divided doses, and fluconazole at 1200 milligrams daily, or 12 milligrams per kg per day for children. If you don't have that, but you have the conventional amphotericin B, you can give it for 7 days of amphotericin B deoxycholate, dosed at 1 milligram per kg per day, plus flucytosine at 100 milligrams per kg per day in 4 divided doses, followed by 7 days of fluconazole at 1200 milligrams per day for adults. So this option two, you are going to give amphotericin B in combination with flucytosine. Option three, we have 14 days of fluconazole, 1200 milligrams per kg per day, and flucytosine at 100 milligrams per kg per day in 4 divided doses. So this is situations where you don't have either formulations of amphotericin B. Option four, um, you may have the liposomal amphotericin B, so you are going to give it at 14 days of liposomal ampho B at 3 to 4 milligrams per kg per day, plus fluconazole at 1200 milligrams per kg. So these are instances where you don't have flucytosine. And option five, where you don't have the liposomal ampho B and flucytosine, but you have the deoxycholate. This is what we are using previously. 14 days of the amphotericin B deoxycholate, dosed at 1 milligram per kg per day, plus pyrofluconazole at 1200 milligrams per kg per day. You may need to consider one consideration that is done here is the issue of costs. If you are to consider something like option one for a 50 kg patient, this patient would end up using around 10 vials of liposomal amphotericin B. The last time we had procured it in our facility, one vial was around 8,000 shillings. So that's around 80,000 as a start dose. And you have to compare that to option four. This patient would need, if you are to dose the patient at 4 milligrams per kg, the patient is going to need 4 vials daily. So that's around 32,000 and using it for 14 days. It's almost over 300,000. So that's one consideration where you'd want to consider in choosing between option one or option four if you have liposomal and for B. One would ask, why all these recommendations? So these were based on some evidences. Uh, the first one that recommended option two was the ACTA trial, which was the Advancing Cryptococcal Meningitis Treatment in Africa. It was done in around 5 centers within Africa, but Kenya was not one of them. So this was a phase 3 and inferiority randomized control trial in 4 African countries. It compared 1 week of amphotericin B deoxycholate with 2 weeks of fluconazole and flucytosine, with 2 weeks of fluconazole plus cytosine, or 2 weeks of amphotericin B and fluconazole. So what it showed was 1 week induction therapy of amphotericin B deoxycholate plus 2 weeks of flucytosine and fluconazole had the lowest 10-week mortality rate. And of note, the one that is giving us option one is the Ambition trial that was published in 2022 by Jarvis. So this is where they gave a single dose, high dose liposomal amphotericin B plus 14 days of flucytosine and 14 days of high dose fluconazole. And they compared that with 7 days of amphotericin B deoxycholate and 7 days of flucytosine, and followed by 7 days of fluconazole, basically option two. And this was an inferiority study, and they showed that it was able to avert all-cause mortality in HIV among HIV patients with cryptococcal meningitis. So there are several other studies that we have not put here, but at least there are some level of evidence that supports the use of a high dose amphotericin B in management of cryptococcal meningitis. So the main thing that we will always get questions is, how do we then monitor? So the first thing, whenever we are administering the high dose amphotericin B, we need to do preemptive hydration, and you're going to use normal saline, at least around 1 liter of normal saline. And in that 1 liter, you should add 20 milliequivalents of potassium chloride, or basically 1 ampule. Then make a supplementation with oral KCl if you have them on day 1, 2, and 3. And also, if you have magnesium tablets or supplementation, you can also give between day 1 and day 3. The whole purpose of prehydration is a concept called salt loading, which helps to reduce the vasoconstriction from the tubuloglomerular filtration mechanisms. And it also helps to to prevent metabolic acidosis associated with amphotericin B. So once you give the liposomal amphotericin B as a start dose, you're going to give 14 days of flucytosine and 14 days of fluconazole, as I had said earlier. In terms of monitoring for kidney function, you need to monitor for potassiums on day 1 and day 3, creatinines on day 1 and day 3, and the hemoglobins on day 1, day 7, and day 14. Also, as we had said, amphotericin B, cryptococcal meningitis also is associated with high ICPs. So you need to do serial lumbar punctures to help relieve that increased intracranial pressures. And you need to do that on day 1. So on every alternate days. So once you do it on day 1, you repeat it on day 3, 5, 7, 9, 11, and 13. It's also appropriate to do repeat cultures around on day 13, just to ensure that you have achieved sterilization of the CSF. We had said amphotericin B causes infusion reactions. So before administration, you can give a start dose of IV paracetamol. start dose of chlorpheniramine at 10 milligrams start, and hydrocortisone. So this one is usually given 15 minutes before or within that minutes after you have given the infusion. So this is just a chart that breaks down the number of vials that you're going to give. So you find for a patient weighing between 51 to 55 kilos, you're going to use 550 milligrams of um, liposomal amphotericin B, and those are around 11 vials. A patient who, say, might weigh 70 kilos, you're going to give around 700 milligrams, and that's around 14 vials. And the volume that you're going to use is around 175 mLs. The important here is most of the infusion bags that you're going to use, they have a capacity of around 500 mLs, and sometimes can be very difficult to transfer all these such a large volume. So it's usually advised that you draw out some volume from the bag before you transfuse, before you mix the liposomal amphotericin B with the infusion fluid. So in terms of its preparation, liposomal amphotericin B is prepared in three main steps. The first one is reconstitution. So you are going to use water for injection because it comes as a dry powder for injection. Uh, you reconstitute with around 12 mLs of sterile water for injection uh, to give you a concentration of around 4 milligrams per ml, which is roughly around the 15 milligrams in that vial. After that, uh, an important thing that maybe I hadn't mentioned, amphotericin B is strictly infused in dextrose. In pediatric patients, you can use 10%, but in adults, we tend to use 5%. And the reason, it precipitates in normal saline. So kindly never infuse amphotericin B in normal saline. So once you have calculated the volume, say you need to use around, you have a patient who weighs 50 kilos, so you need 500 milligrams, so you need around 10 uh, ampules. You need to draw out at least 125 mLs of 5% dextrose, or roughly at least on the lower side on an average of 100 mLs. So that's what this point says. Withdraw the volume of 5% dextrose equivalent to the total dose of amphotericin B liposomal from the 1 liter dextrose bag and discard, because this helps to minimize the pressure and also helps with calculating the flow rate. Then withdraw the amount of reconstituted liposomal amphotericin B into a sterile syringe. The current amphotericin B that we have in our facility comes with a micron filter, which you're going to use. You attach it to the syringe and inject the syringe contents in through the filter into the appropriate amount of 5% dextrose. So two key points here. The first one is, depending on the number of vials you're going to use, draw out an amount, the volume from the 5% and discard equivalent to that amount. Then draw out the number, the volume from the vials of the amphotericin B, attach your syringe to the micron filter, and uh, inject the syringe contents through the filter into the appropriate amount of the 5% dextrose bag. So this is just a screen photo of the liposomal amphotericin B that we have in our facility. And this is the 5 micron filter that you can experience any infusion reactions in any formulation of the amphotericin B. I had said earlier, it's incompatible with a normal saline and kindly avoid using that. Uh, you run the risk of hypokalemia, so supplement potassium, and it can cause an acute kidney injury, so adequate hydration with normal saline. Before you give the liposomal amphotericin B, if you had hydrated your patient, it's advisable that you flush the giving set line with 5%, just to minimize the risk of precipitation. So another important thing, do not confuse the liposomal amphotericin B with the deoxycholate, because you cannot give that high dose using the deoxycholate, or what we call the conventional amphotericin B. Uh, in terms of flucytosine, we had said what we have is the 500 mg tablets. This chart can give you an idea of how you're going, the number of tablets you're going to give. So, say for 50 kg patients, the patient is going to need around 5,000 milligrams or 5 grams, and you can divide that into 4 divided doses, which can, if you have your tablet is cold, you can give 2.5 tablets, or you can even give 3 tablets in the morning after every 6 hours. So you give 3 tablets at 6 a.m., 2 tablets at 12 midday, 3 tablets at 6 in the evening, and 2 tablets at 12 midnight. Flucytosine has been associated with causing nausea and vomiting. And this can be managed by either giving ondansetron or giving the tablets individually over a 15-minute window, because the pill count with flucytosine is a little bit high. I think the least we have given our patients is 2 tablets. In terms of renal dosing for flucytosine, if the GFR is above 40, you are still dosing it in the normal way at 25 milligrams per kg, but you give that 6 hourly. EGFR, so between 20 to 40, you reduce the dosing frequency from 4 times a day to just BD, so 12 hourly. If the GFR is between 10 to 20, dose it after every 24 hours at 25 milligrams per kg. And if the GFR is below 10, you dose it after for more than 24 hours. At least you can consider 48-hour dosing. For fluconazole, if the GFR is above 50, there's no dose adjustment that is necessary. But below 50, you reduce the dose by 50%. For patients on hemodialysis, 40% is usually cleared. So on the day that the patient is on dialysis, you may need to augment by the amount that was cleared. In terms of reinitiation of HIV, this is based on our guidelines. So for patients who are ART naive, you do not start the ART medications, and you need to wait for between 4 to 5 weeks. Actually, our guidelines currently recommend 5 weeks before you start the ART medications. For patients who had been previously on ART medications but were not adherent, you stop the ART medications on admission, and you only you wait for about 4 to 6 weeks and reinitiate or restart depending on the regimen that you're going to transition your patient to after 5 weeks. So for patients who were on ARTs, who had been initiated on ARTs, but for less than 14 days before the diagnosis, you should stop the ARTs on admission and start them again after 4 to 6 weeks. But for patients who had been started on the HIV medications between 14 days to 6 months, so these are newly diagnosed patients who have been on ART medications, but for more than 14 days, but up to 6 months, they can continue the ART medications concurrently with the cryptococcal meningitis treatments. So with that, that's the end of my presentation, and those are the references. So we would invite any questions. Thank you. So
Oh, thank you
Dr.
very
Nyaga,
much,
I hand
Daktari,
back to
for
you.
that very informative presentation. Can you hear me?
Yes, I can.
Yes, I was just saying thank you very much for that very informative presentation. I prompted people to be responding on the chat with any questions they may be having. So far, none have given any questions. So, to everyone in the group, okay, well, I have. This is Ruth Marita saying great presentation. Anybody with a question, please post it on the chat or raise your hand for us to give you the chance to unmute yourself and for you to make your question known to every one of us. We still have around 8 minutes. Well, we'll be sharing. Okay, yes, there is a question from Jane Wanjiko. What volume of dextrose 5% should be used for administration and duration of administration of amphotericin B? I think that had already been covered, but it's okay. You can, Dr. Anthony, you can respond.
Yeah, ideally, we should use about a liter or 5% dextrose. The normal duration, just to minimize the risk of infusion reactions, it should be around 4 hours. You'll find the normal practice, because of the risk of denaturing from the sun, some people tend to cover the infusion bags with some khaki envelopes. The challenge you get is for us, like in a public institution, we really get a 1 liter bag of dextrose. So we end up using the 5%, the 500 mLs bag of 5% dextrose. Thank you. So there's another question from Callisto. Comment on the filtration of photoresin B during reconstitution. I had said earlier, the filtration is going to happen when you are transferring the contents of the liposomal photoresin B from the vial into the infusion bag, the 5% dextrose. We are going to use the transfusion fluid. So you're going to use this filter, this micron filter. Once you have reconstituted with the water for injection and you have drawn out the contents into a syringe, you connect the syringe to the 5 micron filter. This filter has a pore that you are able to inject into the 5% dextrose, and you push the contents through the filter. I hope you have understood that.
And the patient stop fluconazole in the, yeah, Callisto responds in the affirmative. Can the patient stop fluconazole in the maintenance phase if CD4 is high before 1 year is finished? That is from Stephen Lagarde.
Thank you for the question. Actually, the recommendations that I have seen is both in the IDSA guidelines and WHO, and even our local guidelines that we have borrowed from the WHO is on the minimum 1 year, though they had said, so the one is the minimum, but the duration can be continuous for more than 1 year, depending now on the CD4. So if the CD4 normalizes within, because remember also the CD4 measurements needs to be done 6 months apart. Two measurements done 6 months apart. So that puts on the minimum of 1 year. So if the CD4 normalizes, continue for the minimum 1 year, do them 6 months apart.
What are the expected adverse effects of for the patients on both ARTs and the treatment?
Mostly the reason that the guidelines recommend holding off of the ART is the risk of iris. That is what I was able to get. But other than that, maybe you may too be talking in terms of now potentiation of organ toxicities, because something like liposomal photoresin B and its effect on the kidneys. And considering, say, you have a patient who is also on tenofovir, which can still augment the renal toxicities. We had said for fluconazole, what you're going to get a lot is drug-induced liver injury. So that one is not of much worry for patients on our first-line regimen of tenofovir, lamivudine, dolutegravir. I hope I've answered that at some level.
Maybe some people here don't know what iris is. And
Or the immune
very
reconstitution
quickly, you can
inflammatory syndrome.
yes,
Yeah.
just explain for like 2 minutes or so in the simplest of terms. There are some people for sure here who don't know what that
Oh,
is.
no, it's just basically the immune reconstitution inflammatory syndrome. And this occurs once either the patient, once you start the patient on antiretrovirals, where the body is able to resynthesize its own the immune systems that were inhibited by the virus, and then the body is able to detect other infections, and this would present as an inflammatory state, and it usually tends to be highly fatal uh, among patients. So for cryptococcal meningitis, what you'd be worried about is the patient transitioning from a chronic meningitis state to an acute state due to that aspect of inflammation.
Thank you very much. There's another question that is on the Q&A section. Now that liposomal B is less nephrotoxic, is it necessary to also do post-hydration with normal saline?
Yes, it's actually recommended. I think that's one thing I didn't cover. I apologize for that. But yeah, you still need to do a post hydration with another liter of normal saline.
Okay, I believe that's a good number of questions asked. It's now 7:59 p.m. and thank you to everybody for having attended. Thank you, Daktari, for the presentation. Thanks to Mount Kenya East Branch and the head office of the PSK for granting us usage of this link. As we said, we'll be able to send this presentation to everyone who's attended and to also to everyone on our mailing list. Unfortunately, we did not have enough time to have this link up on the portal because of the Easter holiday, but we purpose to have this in our future events to get link information and to be able to put it up together with the event when we are publishing it on the practice portal so that we may be able to reach out to many more people. But for the 100 or so who've been able to join us, we are really grateful to you. So until next time, it's bye for now. And as we promised, we'll be able to accord the CPD points to all the subscribers in attendance. Thank you and good night.
Thank you also.